¿Cómo están todos? Les habla el doctor Carlos Segura, cirujano pediátrico de Lima, Perú. Y deben ustedes saber que el doctor Donald Nuss puso un límite en el antes y el después del tratamiento del pectus excavatum y del pectus carinatum. También hay un antes del doctor Nuss y un después del doctor Nuss. Y precisamente estamos aquí entrevistando al doctor Donald Nuss que se encuentra en Idaho, en los Estados Unidos. ¿Cómo estás, Donald? Te quisiéramos preguntar. ¿Cómo se te ocurrió inventar tu técnica de colocar una barra en el pecho de los chicos que tenían pectus excavatum, es decir, el tórax hundido, y curarlos? Adelante, cuéntanos, Donald.
Good morning, Carlos. Thank you for inviting me. I grew up in South Africa and I did my basic training in South Africa and also my pediatric surgery training. But then I came to the United States, and because pectus excavatum does not occur in the African population in South Africa, I had never seen a pectus operation as advocated by Ravitch and Welch. So the first time, my partner, Dr. George Harkins, invited me to assist him with the case. And you have to know that Dr. George Harkins trained under both Ravitch and Welch, so he was very well trained. I was amazed at how destructive this operation was. To me, it seemed like we were doing a radical chest resection for a patient who did not have cancer. It was the only other time you would do such a massive resection would be for a patient with cancer. However, it was not my patient. I was merely the assistant. So the next time he asked me again, I again was surprised how long the operation took and how much of the chest we removed. And even though the result was reasonable, it was not very good. And then post-operatively, the patients all developed a very hard, rigid, and corrugated chest, which did not move with respiration. And then my partner retired, and all of a sudden, I inherited his patients. And the very first time I operated on a practice patient doing the Ravitch procedure, I was surprised at how flexible the cartridges were when I tried to remove them. And I realized that the chest is very flexible, especially in young children, as advocated by both Ravitch and Welch. And Ravitch even advocated operating on babies less than 1 year of age to do the repair. What I did not know at that time was that the pediatricians and primary care doctors were not referring the patients for surgery anymore because they had seen the long-term results of the Ravitch procedure. And they decided that the operation was worse than the disease. But this I only found out many years later. So after thinking about the flexibility of the chest and having had experience with open heart surgery and colon interpositions for esophageal obstruction or atresia, I was very familiar with that area of the body. And I thought, I can slide a curved steel bar under the sternum and slide it in upside down and then turn it over. And that should correct the deformity. Now, of course, I had no way of testing this. And also, you have to know that at that time, Norfolk, Virginia was a small town with minimal academic oversight because we had just started a medical school. And there were no committees yet to oversee everything. So I was able to do whatever I wanted. So I said to the parents of about a 5, 6 year old boy, it's 40 years ago, so I don't remember exact age. I told them what the Ravitch operation was and that was the normal way of correcting pectus excavatum. But I also told them, I said, I have a new idea, which will require no chest resection. And they said to me, Doc, please do whatever you think is best for our child. So I made the same transverse incision that I would have made for for the Ravitch procedure. But instead of taking the skin and muscles off the chest, I just created enough subcutaneous space so I could slide a curved vascular clamp under the sternum. And remember, I'm sitting on at the top of the chest, and I can see the sternum right under me, so very easy. It took me only less than 5 minutes to make the tunnel, and then once I had a tunnel, I then opened the clamp and inserted a half-inch tape into the clamp and pulled that through. So now I had a tunnel with a tape running through the tunnel. I took the bar that we occasionally used for the Ravage procedure to prevent the sternum from sinking into the chest, and I attached the tape to the bar and then very slowly guided the bar uh, through the chest and out on the other side. Now I had already bent the bar into a curved shape, and I inserted the bar upside down, so the convexity faced posteriorly. And then I got some orthopedic pliers, and I turned the bar over so that the convexity now faced anteriorly. And much to my amazement, it completely corrected the pectus excavatum in this young patient. It was hard to believe that he even had a pectus after we had turned the bar over. At that time, I did not realize how unstable the chest is, because if you think about it, every breath you take, the chest expands and contracts. Every time you bend forward, it flexes, and every time you bend backwards, it flexes, it extends. And then when you bend sideways, it likewise. And then there's also rotation. So the chest is a little bit like the ocean. It's a constant movement in all directions. So I stabilized the bar by placing mattress sutures through the fascia uh, superiorly and inferiorly. And then I closed the incision. And the whole procedure took about 30 minutes. There was no blood loss except for the skin incision. And we got a wonderful result. And so I knew it worked. And then I did not know, however, that we needed to have a strong bar, because over time this bar was not strong enough, and the chest slowly receded. It never collapsed. It never went back to what it was before. But I got a little bit of a carinatum from the depression that occurred after it self-corrected, and we used a brace to correct that. And then, so we had to get a stronger bar. And that proved to be a bit of a problem, because the company that made the original bar would not make me a regular bar. However, then I found a and Walter Lorenz was an individual who made his own instrument. And he said, yes, he would make a bar for me. And it was through Walter Lorenz that I was able to continue. And then later on, he and his team helped me make all the other pectus instruments, which everybody now uses and everybody has copied. Now, once we started doing this on more patients, we realized that older patients had a much more rigid chest, and we started to use 2 bars. And so once I started doing this procedure, I could never go back to doing the Ravage procedure. Thank you.
Thank you. Muchísimas gracias, Donald. De verdad que esta ha sido una historia fascinante. Muchas gracias.